Welcome. This is the first of three modules that you'll have for the remainder of this course addressing topics in cancer. So today will be lung cancer, and the following week, next week, will be breast cancer, and then the final week of school will be prostate cancer. The palliative care topic will be delivered in Dr. Newsom's special topics course, also, I believe, the second to the last week of school. I have to look at my schedule, but that'll be up. Well, originally I'd planned on this to be a self-contained time module within the Canvas learning system, but that's proved a little more difficult than I was led to believe. I'll still continue to work with the Canvas support people, and hopefully we can have a timed module next week for breast cancer, but we'll have to keep our fingers crossed. They are really inundated with phone calls, as all universities and high schools, middle schools are converting to online asynchronous courses. I hope you're all keeping safe and your families are doing well. And my goal here is to present you the material that you will need to be successful in the exam, but not to make it too stressful. I realize that the situation with COVID-19, the stay-at-home orders create a lot of undue stress and tension and a lot of uncertainty. I have, as you know, I have three teenage boys. They're home, and it's really obvious the stress that it's creating for them, especially around the uncertainty and what's going to happen as we progress with this pandemic. So, as I said, my goal is really to just give you the information you need, move forward, and not do it in a fashion that's going to add additional stress to your life. So let's get started. So let's start with some lung cancer facts. And these are facts I'm sure you've seen before in other courses, probably when Dr. Yu covered smoking cessation. Lung cancer is the leading cause of death in men and women in the United States. In 2016, approximately 225,000 new cases of lung cancer were diagnosed in the United States. That equates to 1 in 16 Americans will be diagnosed with lung cancer in their lifetime. It's a disease that affects any gender or ethnicity. Interestingly, 47% of new lung cancer cases are women. We traditionally think of men as the smokers, but we do see that 47% of new cases are women. 10 to 15% of new lung cancer cases are in people that have never smoked. And so part of that we think is from either secondhand smoke, exposure to secondhand smoke, radon, or occupational and environmental exposure, things like asbestos. Lung cancer accounts for 13% of all new cancer diagnosis, and it accounts for 24% of all cancer deaths. So that gives you an indication that people are pretty far along in the disease process when they're diagnosed. Lung cancer kills 2.5 times as many men as prostate cancer, and lung cancer kills 1.5 times as many women as breast cancer. And when we think of women in cancer, we always think of breast cancer being the real culprit and taking lives. But it's actually total number is more in breast cancer, but lung cancer is more lethal. The 5-year survival rate is 18%. This has really improved since the 1970s when it was 13.7%. So we have made some headway with probably early screening more so than some of the chemotherapeutic and radiotherapeutic options that we have. Staging diagnosis accounts for the most marked variation in prognosis. So the higher the stage, the poorer the prognosis. Other contributors to a poor prognosis include age, male gender, and performance score. So obviously, if you have someone that's older, has comorbid conditions, their prognosis is going to be poor than someone who's young and fit. Lung cancer accounted for roughly 158,000 deaths in 2016, and the incidence mortality rate for lung cancer is greater in African Americans than in white. And we think that a lot of that has to do with the fact that many African Americans are more hesitant to seek medical help, medical attention, and often they don't have the resources, socioeconomic resources that whites may have. Rates of cigarette smoking has been on the decline in the U.S. for the past 15 years. So that's good. That's good news. The rate of smoking is on the decline. I've mentioned patient performance score or patient performance status before, and I just want to make sure, so I've included this slide, that you know that the two different performance scoring or status nomographs are the Eastern Cooperative Oncology Group, or the ECOG scoring, or the Karnofsky scoring. The ECOG scoring is probably the most commonly used now because it's so easy. It's a 0 to 5, with 0 being fully active, able to carry on all pre-disease performance without restriction, and 5 being dead. When you look at the Karnofsky score, it's actually the reverse, where 0 is dead and 100 is normal, no complaints, no evidence of disease. But you'll see these reported both in clinical trials and in clinical practice guidelines when you're looking at how to stage a patient and how to select appropriate therapy. So to continue on with the facts, if we look at the etiology or risk factors for lung cancer, and we've not separated out the different kinds of lung cancer, small cell versus non-small cell. We're just talking general facts here. The majority of lung cancer deaths are attributable to cigarette smoking, and I think you all knew that. Compared to never smokers, smokers have had an approximately 20-fold increase in the risk for developing lung cancer. So good reason to never start smoking, or if you are a smoker, to stop, or if you have family, friends that are smokers, to encourage them to stop. Passive or secondhand smoke account for approximately 3,000 lung cancer deaths per year. So if you live with someone who smokes, obviously it'd be to your benefit to get them to stop smoking. Radon, radioactive gas produced by the decay of radium, accounts for 6,000 to 36,000 cases of lung cancer per year. I don't believe radon is an issue here in Texas because of the soil type that we have, but it is, you see it, a real problem in some of the higher, more northern states, Minnesota, the Dakotas, those areas. Radon gas is a problem. They actually have radon gas monitors that you can put in your basement. Occupational exposure to carcinogens, asbestos, arsenic, chromates, ethers, nickel, and others account for approximately 15% of lung cancer. So you can increase your risk for lung cancer depending upon where you work and what your environmental exposure is. So if we look at the relative risk of developing lung cancer, a male who smokes cigarettes has a relative risk of 17.4. A cigarette smoking in females is 10.8. But if you happen to be working with asbestos and a smoker, you have a 28.8 increased relative risk of developing lung cancer. So there are, those. So I've included a slide on relative risk for lung cancer, for developing lung cancer. And you can see that, as you would expect, cigarette smoking increases the risk to develop lung cancer. The risk is greater in males than in females. Not quite sure why that is. Males tend to draw in tobacco a little more than females do. That could be the reason, but we're not quite sure. You've all heard the ads, I'm sure, on the television for asbestosis. Lots of lawyers, if you've been exposed to asbestos, want to take your case and sue whoever you worked for at the time. And you can see that exposure to asbestos is only a 1.2 to 2.6 increase in relative risk. However, if you look at asbestos and combined with smoking, you see that that's the double whammy of 28.8. So these are some facts. I think they're things that you probably already know, but I just wanted to present them again to you. So if we look at the histological classification, so the kind of cell type for the different types of lung cancer, the general histological classifications for lung cancer is either non-small cell lung cancer or small cell lung cancer. And then within those groups, there are subtypes. So in the non-small cell lung cancer group, there's adenocarcinoma or squamous cell carcinoma, and then large cell carcinoma. You'll often see these separated out as squamous cell carcinoma and then non-squamous cell carcinoma, which will include both adenocarcinoma, large cell carcinoma, and then there's also can be a mixed adenosquamous type carcinoma, which we'll talk a little bit later. And then for small cell lung cancer, um, there's really only one type, and it's small cell lung cancer. It's identified by light microscopy. They're a malignant epithelial tumor consisting of small cells with round T fusion shaped scant cytoplasms. They're finely granular, nuclear chromatin and absence or inconspicuous nucleoli. So they're a small cell. I really like. So when we look at the histological classification of lung cancer, there's two general types. There's either non-small cell lung cancer or small cell lung cancer. And then within the non-small cell lung cancer group, there's adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. And that depends on the type of cell that is being affected where the tumor is developed. For small cell, there's just the one type, which is identified by light microscopy. So now we're going to focus on non-small cell lung cancer. So non-small cell lung cancer is rarely diagnosed in a patient younger than 35 years old. It's a slowly progressing disease. The incidence and death rate rises exponentially until age 75, accounts for the greatest number of cancer deaths in both men and women over the age of 60. The geographical, social, and temporal trends of the incidence of non-small cell lung cancer are closely related to tobacco consumption. So this is really a disease of smokers. The incidence of non-small cell lung cancer has been declining in the Western countries, and that's due to the fact that we're not smoking as much. However, it has been increasing in Asia, Eastern Europe, and the developing countries. And so we're going to see this increased burden, economic burden on the developing countries because this is an expensive disease to treat. So we will see that economic burden those countries will have to. So now we're going to focus on non-small cell lung cancer. And first we'll talk about the epidemiology. So it's rarely diagnosed in a patient younger than 35 years old. The incidence and death rate rise exponentially until age 75. And it accounts for the greatest number of cancer deaths in both men and women over the age of 60. So this is a slowly progressing disease that usually, when a patient presents, they're usually 50 years or older. The geographical, social, and temporal trends of the incidence of non-small lung cancer are closely related to tobacco consumption. So within this country, we're using less and less tobacco, so you're seeing that decline in non-small cell lung cancer. And you'll also see that educated people, so people with college degrees, are less likely to smoke versus uneducated. So there's a difference between blue-collar and white-collar workers and professionals. You also see the incidence of non-small cell lung cancer has been declining, as I said, in the Western countries. However, it has been increasing in Asia, Eastern Europe, and developing countries. And this is a real concern because it's a costly disease to treat. It really impacts the economies of countries because you lose people in the workforce, you lose breadwinners, etc. And African Americans might be more susceptible to the carcinogenic effects of tobacco smoke. However, this is really kind of confounded by socioeconomic uncertainties. So when we look at the etiology of non-small cell lung cancer, there is a little bit of a genetic predisposition. So a family history of lung cancer is associated with a twofold increase in lung cancer risk, even after correction for smoking. So even if you're not a smoker and you correct for that, or if you are a smoker and correct for it, there is a greater risk if you have first-degree family members that have had lung cancer, and it's not clear why. There is a weak but consistent association between some polymorphisms and lung cancer risk. So we know that the liver plays an active role in metabolizing all the many combustible carcinogens that are in cigarette smoke. And so you can see some mutations, some single point mutations, such as CYP1A1, which is associated with a higher risk of lung cancer in Asians. You can see polymorphisms in glutathione as transferase that increases the risk also in Asians, and then polymorphisms in DNA repair enzymes, which also increase the risk. And these are single point mutations, so there's just one amino acid swapping for another amino acid, but it does increase the overall risk for lung cancer. Let's talk a little bit about prevention. you all know the best way to prevent lung cancer, and that's through smoking cessation. That's not news to you. The good news is, as Americans, we're smoking less and less, and you can see that in 2012, it was estimated that 18.1% of Americans smoked. That's down from 42.5% in 1965. We're have over the last probably 10 years, 15 years, started to see the decline, obviously, in lung cancer, but it takes that long of time span to start to see a decline because it's a disease that takes 20 to 30 years to develop. So now let's talk a little bit about detection. You're all too young to remember, but the American Lung Association, when I was in middle school, used to have a mobile truck that would come around and do chest x-rays. And they were looking for detecting, early stages of lung cancer. The problem with that is that both chest x-rays, even with or without sputum cytology, failed to show a clear benefit in the early detection of lung cancer. So it was not a reliable screening tool. By the time the tumor was large enough to be detected on a chest x-ray, the patient was well into stage 3 or stage 4 of lung cancer. So it wasn't a good early detection and screening tool. However, spiral CT, also known as low-dose CT or helical CT, is more sensitive than chest x-ray. And the National Lung Screening Trial, which was a large trial, showed that actually this was a sensitive method to use for early detection and screening for lung cancer. So let's spend a moment and look at this National Lung Screening Trial. The results were published in 2011. So let's spend a moment and look at the National Lung Screening Trial, which the results were published in 2011. So the trial design was randomized. So a patient was either randomized to a yearly chest x-ray or a yearly low-dose CT. So they were given a yearly x-ray or CT, and they were followed for 3 years. So what was the inclusion criteria? Current or former smokers aged 55 to 74 years old with at least a 30-pack year smoking history and no signs or symptoms that could be related to lung cancer. So people that have had enough exposure that they would potentially develop lung cancer. So it wasn't new smokers, it's someone with a 30-pack year history, but they couldn't show any signs or symptoms because we were using this as an early screening or diagnostic tool. So we didn't want to have any signs or symptoms of lung cancer. And what were the results? After a median follow-up of 6.5 years, the low-dose CT cohort had a 20% reduction in the rate of lung cancer and specific mortality, as well as a 6.7% reduction in overall mortality. That's really pretty profound. So sensitivity and specificity for low-dose CT was 93.8% sensitive, but only 73.4% specific. So it had low specificity compared to the chest x-ray, which was 73.5% sensitive, but much more specific. Well, the reason for that is when the chest x-ray, the reason it's more specific is that what the chest x-ray is picking up is a large tumor. What the CT scan is picking up are small little cell clusters that were often benign. So that's why the low specificity for the CT scan compared to the chest x-ray, but the higher sensitivity for the CT scan because you could pick up malignant cells in smaller groupings than you could on the chest x-ray. So when they did the cost effectiveness analysis, it showed a median cost of $43,000 per quality adjusted life year gained for current smokers assigned to the low dose CT cohort. So economically, everything lines up. So what's the recommendation been? And you've probably heard of the U.S. Preventive Services Task Force before. They have other screening recommendations. They have the breast screening recommendations. So what do they recommend? They recommend yearly low-dose CT screening for lung cancer. And who do they recommend that for? Current or past smokers, 55 to 80, with a smoking history of at least a 30-pack years. Now, screening can be stopped once a person has not smoked for 15 years. So if you are 80 years old and you stopped smoking when you were 60, then you wouldn't be eligible for the screening. And so this is available, but not many people partake of the screening. They're just not aware of it. They're just not aware of it. So if you have a grandfather or someone that you know that's been a constant smoker, has never had a CT screening, they fit the criteria, you should really urge them to do that. Most insurances will pay for it. So now we're going to move on to classification of non-small cell lung cancer. So we're going to look at the adenocarcinoma and then the squamous cell carcinoma. We're not going to really look at the large cell carcinoma. So let's start with the adenocarcinoma of the lung. It's a cancer that forms in the mucus-secreting glands, so it is a granular tumor. The tumors will arise from surface epithelium or bronchial mucosal glands and are most commonly located peripherally. This is the most common subtype of non-small cell lung cancer, representing 40% of the cases in men and 50% of the cases in women. Interestingly, about 75% of the adenocarcinomas of the lung have alterations in driver genes that activate intercellular pathways. Unfortunately, this is good because these are potential targets for drugs, but unfortunately, we only have a few drugs against some of these specific targets. So activation of these pathways leads to increased cellular proliferation, cell survival, and oxidative stress response. So it's that we don't have enough brake, but we got a lot of gas, and we get rapid proliferation. Many of the pathways that are activated are members of the RKF, RAF, RAS pathways and ERB pathways. And as I said, these pathways, these mutations of the pathways provide potential targets for drugs. And I know that Dr. Abdelaziz has covered that with you, and we'll talk about some of the newer drugs and targets a little later on. So let's talk about squamous cell carcinoma of the lung. So it's a cancer that forms in the squamous epithelium of the lung, hence squamous cell carcinoma. It's most commonly found in the central proximal bronchi and can lead to bronchial obstruction with resultant atelectasis or pneumonia. It's the second most frequent non-small cell lung cancer, accounting for approximately 25% of new cases. Has the strongest association with cigarette smoking. 80 to 90% of the patients demonstrate TP53 mutation. 45% of the patients have PI3K, ATK, or mTOR alterations, and 26% of the patients have RTK, RAS, RAF alterations, but only 1 to 6% have EGFR and KRAS alterations, and that's really where we have some drug targets. So the last class is large cell carcinoma, and it's an uncommon carcinoma. It's the least common of the non-small cell lung cancer subtypes. Accounts for only 8% of all cases, and we're really not going to cover it any further here. So key things to remember. Remember that adenocarcinoma is peripheral. Squamous cell carcinoma is central. And then look at the representation of the percentage of cases and then the number of cases between men and women. So let's move on to clinical presentation. So most patients present asymptomatically at diagnosis. They've come in for some other reason. They're having a chest x-ray or a CT for something else. Maybe they fell and they thought they cracked a rib, and they have a chest x-ray or CT and they find out, oh, wow, there's a tumor there in the lung. Or for physical assessment for another reason, and it's their breath sound funny, so they get a further workup. But it's usually not, the reason that they've come in is usually not because of symptoms specifically associated with non-small cell lung cancer. So when symptoms are present, though, they are more commonly related to the specific location of the tumor and the tumor type. So for adenocarcinoma, which are central tumors, usually you'll see cough, hemopsis, wheezing, stridor, and dyspnea. For the peripheral squamous cell type carcinoma, you'll see pain in pleural or chest wall invasion, cough, and restrictive dyspnea. So when you do see symptoms, they're a bit different, but the majority of patients, the vast majority of patients, present asymptomatically. So if the tumor mass involves thoracic and cervical structures, This can lead to a bunch of different syndromes. And we talked about those syndromes when we talked about oncological emergencies. So Pancoast syndrome, which is shoulder pain radiating to the arm and the ulnar distribution, caused by an invasion of the eighth cranial nerve, first thoracic nerve. So that's the tumor, the bulk of the tumor is impinging on those nerves. And so oftentimes patients will present with shoulder and arm pain, and you have to think, is it something that they've done? Are they tennis players? But it's really associated with lung cancer. Hoarseness, so their voice is hoarse, involvement of the left recurrent laryngeal nerve. We've talked about superior vena cava syndrome before, so swelling of the face and arm and superficial venous engorgement caused by compression of the superior vena cava. And then Horner syndrome, which is signs and symptoms related to a disruption of the nerve pathway from the brain to the face and the eye. Usually you'll see one-sided, so it kind of can mask a stroke. Signs include decreased pupil size, drooping eyelid, and decreased sweating on the affected side of your face. You usually don't see the involvement with the mouth and lips that you would see in a stroke. So let's talk about paraneoplastic syndromes that are secondary to non-small cell lung cancer. We talked about paraneoplastic syndromes when we talked about the oncologic emergencies. These are syndromes that are caused by usually the tumor producing a hormone or hormone-like substance. The most common is cancer cachexia, which is a wasting disease. It's characterized by weight loss, impaired immune function, and weakness that is not explained by diet. So we always ask that question, have you had any rapid weight loss? And that can be one of the first signs of cancer that people will recognize. Well, wow, yes, I've lost 15 pounds in 2 weeks. That's kind of unusual. And so that can be related to cancer cachexia. The second most common is hypercalcemia, and can be caused by ectopic production of parathyroid hormone-related protein or bone metastases. And so we see this is common with squamous subtype, and we do see bone mets with a squamous subtype. And then the last is hypertrophic pulmonary osteoarthropathy, which is a clubbing, and I just butchered that, but we'll move forward, which is a clubbing of the fingers and the toes, most common in adenocarcinomas or large cell carcinomas. Let's move on to diagnosis. The first step is taking a good history and physical. So you want to do a complete history, including exposure to cigarette smoke. Were they a smoker? Was it secondhand smoke? Was it environmental toxins that they were exposed to? Maybe they were a welder or a miner, and then also the industrial carcinogens. Then a family history of lung cancer and other cancers. So is lung cancer a problem in their family? Maybe it's colon cancer, but what are their overall cancer risk in that family? And then a timeline of symptoms. And often these symptoms are unrecognized. So you'll have patients say, oh yes, I started to lose weight 2 months ago. My shoulder started to hurt. I was coughing up blood. So they're unrecognized, but as you work back, they start to see that there were symptoms. They were just being overlooked. And then obviously a complete review of systems with labs. You need to set the baseline and then performance scoring. Where do they fit on that ECOG scoring or the Karnofsky scoring? Because this is all going to be considered when you do the staging, and then you talk with the patient and you determine what's the therapeutic approach going to be. Next, imaging studies need to be ordered. So usually chest x-ray, CT scan, PET scan, and endobronchial ultrasound. So x-ray and CT and PET are most useful of the imaging techniques. X-ray is usually the first imaging that's done and can be useful in determining size. CT is useful for small nodes, really looking at regional nodes, those things. PET scans are the most accurate and can help you determine benign lesions from cancerous lesions based on metabolic activity. And part of the reason for the imaging studies is to determine the best route for conducting the biopsy. So as you do the imaging studies, especially when you can use computerized volume modeling, you'll know how to conduct the biopsy. And the biopsy should be done using the least invasive method. So you can do sputum sampling, you can do bronchoscopy, mediastinoscope, or percutaneous needle biopsy, and all the way to open lung biopsy. Usually It's usually a bronchoscope to actually visualize it, and then a fine needle biopsy, a percutaneous needle biopsy. And then lastly, you want to send all the information to the lab where they're going to do the histology. They're going to type it. They're going to look to see are there any molecular markers on it, which may lead to targeted therapy. And then you're going to go through and look at developing the stage that the patient is at. So the staging for non-small cell lung cancer is based on the TNM stage, which is tumor nodule metastases. And I think Dr. Laredo covered this with you, but I'll go through it again briefly. So T is the primary tumor. The classification is T1 through T4, and it's based on the size of the tumor, the invasiveness of the tumor, some other things, and there are some subclassifications. N is the regional lymph nodes. They're classified N0 through N3, and the classification is based on the number and location of lymph nodes. M are the distant metastases, and it's either M0 or M1. Classification based on metastases location, ranging from no metastases to distant metastases. Once the determination for the TNM stage is completed, then the information is used to actually stage the patient. And then the staging is reported as either 1A, 1B, 2A, 2B, 3A, 3B, and 4. Each stage has a predicted 5-year survival rate associated with it. So part of the staging is you can look at where the patient is in the disease. It will guide you to evidence-based therapy, and then you have a predicted kind of 5-year survival rate that you can talk to the patient about. So let's talk a little bit about staging. I put together these two tables, and they're highly abbreviated from the NCCN guidelines for non-small cell lung cancer. I just wanted to give this so we could talk about staging. I believe Dr. Laredo talked about staging, but I just want to go over it again to make sure that you understand it. So you never use this to actually stage a patient because not all the information is there, but enough's there to demonstrate how you would stage a patient. So the first thing you do is look at what's the tumor, how large is the tumor, and you can see that the staging for the primary tumor is T1 through T4. And it's based on size. So a T1 tumor is less than 3 centimeters. A T2 tumor is 3 centimeters, larger than 3 centimeters, smaller than 7. T3 is larger than 7. And T4 is a tumor of any size, but that's invasive, and which means it's an aggressive, highly aggressive, active tumor. When you look at the lymph nodes are N0 through N3, with N0 being no regional lymph node metastases, N1 being ipsilateral, peribronchial or ipsilateral hilar, then N2 metastases in ipsilateral mediastinal and subcranial, and N3 is metastases in contralateral mediastinal. So as the lymph nodes, more and more lymph nodes are involved farther and farther away on it, and then on the other side of the lung, the lymph node number goes up. And then lastly, we have metastases where M0 is no distant metastases at all, M1 is a distant metastases, and M1 is a separate tumor nodule and a contralateral lobe. It was M1A. So you take this information about the patient, about their primary tumor, the lymph nodes and metastases, and then from that, you look at that combination, and then that should take you back to a staging. So as an example, if we look at a tumor that is a T2 tumor, so 3 centimeters, bigger than 3 centimeters, but less than 7, with no regional lymph nodes or no metastases, that is a stage 1B. So the stages here 1B are 1A, 1B, 2A, 2B, 3A, 3B. This should not be 2B, it should be 3B, and then 4. And the difference between the 3B in the lighter versus the 3B in the blue, which is under it, is that it's any tumor with an N3 and 0 metastases is a 3B, where the above is a T4 with an N2. So as you increase the number of lymph nodes that are involved, it can be any tumor. It can be a T1 tumor, a T2 tumor, but if you have that much spread throughout the body as picked up in lymph nodes, then it's 3B staging versus 3A. And then 4 is any tumor, any N, but distant metastases. And then you can see the survival rate with a 1A being at 73% for 5-year and a 4 being at 13%. And the 3s actually being lower than the 4s. And no one quite rightly knows why that is. So let's talk about some of the treatment options for non-small cell lung cancer. So depending upon the stage, will also determine what treatment modality we'll use. But let's just consider non-small cell lung cancer. So we have surgery, which can be curative or palliative, bulk reduction. We have radiation, which again can be curative or palliative and bulk reduction. Then we have chemotherapy, which is what we're most interested in. Adjuvant chemotherapy, which that's chemotherapy that's given with curative intent in addition to the primary initial therapy to maximize its effectiveness. So it may be surgery was the primary therapy. They're going to reduce, they're going to remove the tumor and resection the lung, but they want to make sure that if any cells are left, that those cells are addressed, or any micrometastases that may be out there. So they offer adjuvant chemotherapy to the patient. Then there's neoadjuvant chemotherapy, and that's chemotherapy that is administered before the primary treatment. So if the primary treatment is surgery, you could give chemotherapy prior to the surgery. This is often used before surgery because it will often shrink the tumor and helps define the borders around the tumor, which makes it easier for the surgeon when he's looking at resecting the lung, because you want to have clean borders that have no malignant cells. So oftentimes neoadjuvant chemotherapy is used. And then there's palliative chemotherapy, chemotherapy that is administered with the intent to improve quality of life. It's usually less intense, obviously, than adjuvant chemotherapy or neoadjuvant chemotherapy, but it's really about improving the quality of life and slowing the progression of the disease. Chemoradiotherapy, this is the combination of chemotherapy and radiation, and it may be sensitizing chemotherapy that you're using. We know cisplatin, as you recall, is a sensitizing agent, and it can either be concurrent or sequential. Most of the trials support the use of concurrent chemoradiotherapy if the patient can tolerate it, So now let's move on and look at treatment for stage 1 and stage 2 disease for non-small cell lung cancer. Surgery is the standard for stage 1 and 2 non-small cell lung cancer. Prior to surgery, the patient should undergo a pulmonary function test to assess if they will have the pulmonary reserve, the pulmonary function after surgery to withstand lung resection, because you're going to be removing a large portion of your lung. If they had COPD, some other obstructive disease, they may not have the lung capacity then to recover from surgery. So there has to be pulmonary function test done early. So the patient's performance status and comorbid conditions need to be considered when determining if the patient is a good surgical candidate. That obviously makes sense. Do they have heart disease? Some other disease that would make them a poor candidate for surgery. And then the type of surgery matters. So the extent of the lung resection will be dictated by the size and location of the tumor. The entire tumor is removed with margins negative for cancer. So they look at the tumor and they actually move out beyond the tumor border, and then they'll send that to the lab pathology right away, usually while the person's still on the table. A pathologist will then look at the margins of the tumor to make sure that the margins are clear, that they don't show signs of the tumor. And if so, then they resect the lung and close the patient back up. If not, you definitely see this when breast cancer. If not, then they'll continue to remove more tissue. So lobectomy and pneumoectomy are preferred. So really just removing minimal tissue around the tumor, so you're in that safe zone, versus a big wedge resection or a segmentectomy, which is removing more of the lung. So there is preferred types of surgery. Radiation therapy is a consideration as primary therapy in those patients with stage 1 or stage 2 disease that are poor surgical candidates. And this may be they're a poor candidate because they have no pulmonary reserve, or they have a medical comorbidity that would make them a poor surgical candidate, such as diabetes, heart failure, uncontrolled hypertension. Usually in that case, they'll move to radiation therapy. And stereotactic radiosurgery is one of those modalities that they'll use. It has good local control rates of about 90% and a good 3-year survival at 88%. Adjuvant chemotherapy is also part of the therapy and approach for stage 1 and stage 2 disease. The benefit is the eradication of micrometastatic disease before it becomes clinically evident. There have been many meta-analysis that demonstrate that adjuvant platinum-based chemotherapy is associated with an absolute benefit and 5-year survival of about 5%. So the key takeaway here is that it's the platinum-based therapies that are the most effective. So that can be a platinum doublet or a platinum triplet. Patients with a primary tumor of 4 centimeters or less than 4 centimeters, and a node negative, adjuvant chemotherapy is not recommended. So if you have a small tumor, T1, and your N0, adjuvant chemotherapy is not recommended if the surgical resection or the radiation therapy was effective. Tumor shrank or the tumor was completely removed. The most common platinum-based doublet is the cisplatin and vinorelbine, which has been the most studied and the most commonly used. Other options include cisplatin and etoposide, and cisplatin and pemetrexed, and carboplatin and paclitaxel. The cisplatin and vinorelbine and cisplatin and etoposide are given on 28-day cycles, and it's usually 4 cycles that are given to a patient as adjuvant chemotherapy. And then for the cisplatin and pemetrexed, and the carboplatin and paclitaxel, those are 21-day cycles, and again, 4 cycles. Currently, there's no evidence that supports the use of targeted therapy such as bevacizumab, erlotinib, or crizotinib in the adjuvant setting in stage 1 or stage 2 disease. So those agents are not used. So when we talk about neoadjuvant therapy, there is some rationale, some theoretical advantages over adjuvant therapy, though adjuvant therapy is usually considered standard of care. The advantages are better patient compliance because they've not undergone surgery. They're usually their performance is higher. They're not recouping, so they usually tolerate the chemotherapy better. Remember, cisplatin and carboplatin are tough drugs. They cause a lot of emesis and other side effects. So the compliance can be a little better with neoadjuvant therapy. Improved tumor resectability because usually you get better margins and better borders. Earlier treatment of micrometastatic disease, and earlier assessment of clinical and pathological response. So you're going to know, is a tumor shrinking? That's going to respond to this therapy. Currently, however, adjuvant chemotherapy, as I said, is the standard of care for stage 1 and stage 2 non-small cell lung cancer. The use of adjuvant radiation or chemoradiation in stage 1 and stage 2 is considered detrimental, especially in patients that have had surgical resection. It's not used. It actually decreases overall survival. So let's move on to stage 3. Stage 3 is divided into 2 subclasses, 3A and 3B. Stage 3 can present as a combination of TNM, and so I've showed you the most common combinations that would get you to a stage 3A. And then stage 3B presents as really just 2, a TN4 and 2 M0, or any T with a N3 with, as I said earlier, with a greater spread of nodes. The bottom line is that stage 3 is a more advanced disease than stage 3B is a more advanced disease than stage 3A, characterized by either a larger tumor that is invasive plus greater involvement of regional lymph nodes, or a tumor of any size with the highest level of regional lymph node involvement when compared to stage 3A. So stage 3B is a much more advanced disease. So the treatment options and approaches differ between 3A and 3B. So patients with stage 3 disease, regardless of subclass, have better outcomes with multimodality rather than single modality therapy. For stage 3A, um, surgery plus adjuvant chemotherapy is preferred if the patient is a surgical candidate. If the patient's not a surgical candidate, then alternately chemoradiation followed by surgery has shown benefit in 3A patients. You can also use single modality chemoradiation with a concurrent chemo plus radiation being preferred. For stage 3B, chemoradiation is the standard of care. Concurrent chemoradiation um, has a higher incidence of toxicity, however, it is also associated with a higher survival rate. So, when compared to sequential chemoradiation. So, if the patient has a performance score and can tolerate it, you want to give the chemoradiation concurrently. So, common chemotherapy regimens for use with chemoradiotherapy for stage 3 non-small cell lung cancer are carboplatin and paclitaxel, carboplatin and pemetrexed, and cisplatin and etoposide. There is no definitive data on adjuvant targeted agents for the treatment of stage 3 disease also, so those agents are not used. So let's talk about stage 4 non-small cell lung cancer, and this is really, um, a lot of patients present at stage 4 because they were asymptomatic um, until stage 4, when you really get a lot of tumor bulk and you start to have some difficulty with lung function and a lot of cachexia, a lot of weight loss and pain. So stage 4 is an incurable disease, and management should include adequate palliation of symptoms. So this is really where we get into the fight for extending people's lives by weeks. So patients with symptomatic brain or spinal cord metastases, hemoptysis, post-obstructive pneumonia, or painful bone metastases should receive radiotherapy before any consideration of systemic therapy. So radiation is really good at reducing tumor mass size and especially for bone mass and reducing pain. Early referral to palliative care have been shown to improve quality of life and actually improve overall survival. And we'll talk about palliative care when we do the palliative care section at the end of the semester. Median survival for a newly diagnosed stage 4 patient is only 16 to 17 weeks. And that's where I say we really, when we look at treatment, we're really fighting for weeks to extend their life by just weeks. 1 year survival is 10 to 15%. Patients that respond to targeted therapy improves 1 year survival to 35%. But very few of the tumors actually have the molecular markers or the changes that allow them to use targeted therapy. Systemic chemotherapy, the goal of chemotherapy in stage 4 disease, as I said, is palliative, improve quality of life, reduce disease burden. Chemotherapy can be divided into different stages, and the stages are first line, then maintenance, second line, and subsequent treatment strategies. So what is first line chemotherapy? Well, based on best evidence, the platinum-based doublet therapy. So we're looking again at cisplatin and carboplatin plus an additional agent, maybe etoposide, maybe venrelabine. Maintenance chemotherapy is systemic chemotherapy in patients that have had a response or stable disease after the first line therapy. So we've started them on a platinum-based doublet. They've responded. The disease is not progressing. So now we're going to put them on maintenance chemotherapy to keep the disease from progressing and hopefully extend their life. That's what we're looking at with maintenance chemotherapy. When we move on to second-line chemotherapy, that's actually after the disease has progressed or there's been a cumulative toxicity that the patient can no longer tolerate on the maintenance chemotherapy, and now we need to look for a second-line therapy. Immunotherapy has really become the cornerstone of second-line therapy, and if you look at the FDA regulations around prescribing immunotherapy, it's usually after progression on a platinum-based therapy. So using agents like nivolumab or pembrolizumab are the two of the agents that we use. So one of the things that's critical in stage 4 cancer is the tumor histology, because that is really used to direct systemic therapy. So is it a squamous cell carcinoma or is it a non-squamous cell carcinoma, which would be an adenocarcinoma or large cell carcinoma? So if it's a squamous cell carcinoma, the first-line therapy, again, is a platinum doublet with the best results from either carboplatin and paclitaxel or cisplatin and gemcitabine. So platinum-based chemotherapy provides a modest benefit over non-platinum-based regimen. But again, remember, we're fighting for weeks here. Um, Recently, nivolumab was approved in combination with cisplatin and gemcitabine for advanced squamous cell carcinoma. It goes by the brand name Portraza. It's a monoclonal anti-EGFR antibody. As we know, EGFR is overexpressed in many solid tumors, including colorectal, head and neck, pancreatic, breast, and non-small cell lung cancer. It only has the approval, however, to be used in combination with cisplatin and gemcitabine in the treatment of metastatic squamous non-small cell lung cancer. It's not approved for non-squamous non-small cell lung cancer. So that agent's used as an add-on. Non-platinum-based regimens are used in patients that are either not responsive to platinum-based regimens or platinum-based regimens are contraindicated. So again, preferentially, we want to use a platinum-based regimen. Non-platinum doublets are gemcitabine and paclitaxel or gemcitabine and docetaxel. Those would be alternatives if the patient can't tolerate a platinum-based regimen. For either platinum or non-platinum-based doublet regimens, there is no real benefit beyond 3 cycles. So usually, they'll treat the patient for 3 cycles, and then they'll look at alternatives. It doesn't really improve survival rate. So they'll treat for 3 cycles and then put them on maintenance therapy, which is oftentimes the same doublet, but at a lower, less intense dose. So if we now look at second-line therapy for squamous cell carcinoma, classically second-line therapy consisted of monotherapy with docetaxel. Targeted therapy, EGFR tyrosine kinase inhibitors are not used as EGFR mutations are rarely seen in squamous histology. Ramucirumab, a VEGFR2 monoclonal antibody in combination with docetaxel as second-line therapy, has demonstrated an improved survival of 4 to 5 months versus 3 months compared to just docetaxel alone. So you can see the addition of the monoclonal antibody increases life expectancy survival by 1.5 months, 1.5 months. As I said, we're fighting for weeks here. And the PD-1 immune checkpoint inhibitors, nivolumab and pembrolizumab, have demonstrated benefit as second-line agents also. But the cornerstone to second-line therapy is docetaxel. So let's now talk about adenocarcinoma or non-squamous cell carcinoma. So the recommendation is all adenocarcinomas and mixed adenosquamous carcinomas should undergo evaluation for EGFR mutations, ALK and ROS1 translocations, BRAF mutations, HER2 mutations, and RET fusion. Molecular profiling can guide targeted therapy. Unfortunately, the majority of non-small cell lung cancer patients do not have a tumor that is targetable with a targeted therapy. So if you're lucky enough to have a mutation that has one of these molecular markers, then obviously it would be warranted to try the therapy. And usually the response is very good. But not everyone has these. And I know that Dr. Ritter mentioned that she has had a study going on looking at ALK1 mutation and hasn't found a patient yet in East Texas. So cytotoxic chemotherapy really represents the standard of care. And again, it's that platinum-based doublet therapy that shows the most benefit. So we're looking at things like cisplatin at 75 to 100 milligrams per meter squared, or carboplatin at a target AUC of 6. Addition of targeted therapy if appropriate. So if they have a molecular marker and there is a targeted therapy that you can use, then that is appropriate. Obviously, you want to add the supportive therapies. Cisplatin, the platinums are highly emetogenic, so you want to put together treatment guidelines for both acute and delayed phases, and that would always, in this group, because they're highly emetogenic, include serotonin 5-HT3 subtype receptor antagonist, something like ondansetron, a neurokinin receptor antagonist like Amend, and then a glucocorticoid like dexamethasone. Obviously, you want to treat pain, mucositis, neutropenia, metabolic abnormalities, etc., you want to look at the patient as a whole and make sure that you have appropriate supportive therapy. And really, this is viewed as palliative therapy. So oftentimes, the doses that you're going to use will be less heroic because your intent is not cure, but your intent is to slow the disease down and to add life expectancy. So I put together this little flow chart for the treatment of advanced non-small cell lung cancer for stage 4. This is an adaptation from a chart that you would find in the Bethesda Handbook for Oncology, which is the National Cancer Institute's handbook. But I think it's a very good presentation. May make things a little easier for you to understand. So at the top, you see this is advanced non-small cell lung cancer, stage 4. And then again, we have the two different histologies, non-squamous, which is the adenocarcinoma, and then squamous. So if we look under the non-squamous histology, there are 3 boxes. The tumor can either be EGFR ALK negative. In that case, you would move right down to first-line therapy with a platinum-based doublet chemotherapy, and you can use that for maintenance therapy also. If they're EGFR mutation positive, you would look at using erlotinib. So one of the NIBs, targeted therapy would be appropriate. And if the patient has an ALK mutation positive, crizotinib or one of the other agents that's used as targeted therapy for ALK mutations. So as we continue on down, you can see the blue bubble off to the left. It says that progression or rebiopsy. So if the patient is on either an EGFR targeted therapy or an ALK mutation targeted therapy, and they progress, so they're no longer responding to the agent, you should do a biopsy. So you should rebiopsy at that progression, and then look at the cell markers and see if they've changed at all. And if they've changed or there's no resistance, then you may want to, if you go to the blue bubble all the way to the right, consider alternating the target therapy, just switching over. If they develop a resistant mutation, then you're just going to move on to the platinum-based doublet chemotherapy. So if they've now failed, no matter which of the 3 boxes they came out of, if they're EGFR ALK negative or if they have one of the mutations, but if they've now failed first-line therapy, then second-line therapy would be immunotherapy with nivolumab or the other agent. And that would be second-line therapy for stage 4. And then if they failed that, the disease progresses, then you would need to look at subsequent therapies, and then that's when really we start throwing the kitchen sink at them. So now if we go over to squamous histology, we go right to the platinum-based doublet chemotherapy, and we use that for first line and for maintenance usually. And once they progress, then we go on to immunotherapy, and then if they progress from immunotherapy, then we, again, kind of look at the kitchen sink and what can we put together and hope that they will respond to. So that is the flow chart for the chemotherapy for stage 4. So let's move on and talk about small cell lung cancer. I only have a couple slides left here. Small cell lung cancer makes up approximately 13% of all new lung cancer malignancies. It's primarily a disease of the smoking population. It's a very aggressive disease. However, if detected in the early stages, multimodal therapy can result in prolonged survival. It's very responsive to chemotherapy, but it often relapses, and when it does, it's a poor prognosis. And this is a problem with small cell lung cancer, is that patients that have small cell, no matter if it's limited or extensive, they usually get a very good first response from chemotherapy. And they actually think, wow, this is great, I'm going to do well. But when you see the numbers, when it comes back, when it relapses, it comes back with a vengeance, and it's extremely aggressive and usually resistant to chemotherapy. So clinical presentation, symptomatic presentation, secondary to bulky local regional disease and presence of distant metastases. So unlike non-small cell, people will come to the doctor seeking wanting to find out what's going on with me because they either have dyspnea, they have breath sounds, they have post-obstructive pneumonia, common sites, they have common sites for metastases or brain, liver, bones, and adrenal glands. The staging for small cell is really easy. It's either a limited stage or extensive stage. Limited stage is a stage that can be encompassed in one radiation field. It's amenable to definitive chemoradiation, so it's a very compact, small area. Extensive stage disease is a tumor burden that extends beyond one radiation field, and then treatment is usually palliative for extensive stage. So when we look at small cell lung cancer, the survival, when we look